Hi, my name is Carrie Kovarik, and I'm a dermatologist and dermatopathologist at the University of Pennsylvania. Today, my colleague Kagiso Ndlovu and I will be speaking to you about our global health informatics collaboration, as well as our journey to create a sustainable health informatics infrastructure and workforce within Botswana. I will first take you through an overview, and we will highlight successes and challenges, and we will share insights into what helped our team thrive. Before I continue, I'd like to recognize Ryan Littman-Quinn, our Botswana in-country director and advisor for almost 10 years, for his contribution to this work and PowerPoint. And at the end of our entire talk, we will quickly show you how many people have contributed to this program and how it truly takes a global collaboration for success. Today, I'll focus on our work in Botswana. This is a country of about 2 million people spread across land about the size of Texas. The burden of HIV and TB on the health system is significant, and training and retaining skilled healthcare workers of all disciplines is challenging. Health informatics, as most of you know, is a field concerned with the optimal use of information, often aided by technology, to improve individual health, healthcare, public health, and biomedical research. In order for data to be properly used, it has to be distributed to build knowledge. This can lead to informed policy decisions, improved efficiency, decreased human error, and evidence-based care. Health informatics lies in the center of these three fields: healthcare, computer science, and information science. But in order to build health informatics, we really have to build all three of these fields. When I started working in health informatics in Botswana, there were 40 or more disparate IT systems in the government healthcare clinics and hospitals with almost no integration. That improved to about 12 in 2018. There was one IT officer per 20 to 30 health facilities per district. And in 2018, they were recruiting 400 health information staff, which was really amazing. We still had challenges like landline IT infrastructure, which is still expensive and unreliable, but is improving. Our true capacity building was jump-started with a health informatics capacity building grant from the CDC in 2011. We were tasked with creating and building a field that really didn't exist. We realized we needed to build a sustainable ecosystem, which was based on this pyramid, with awareness building and advocacy at the base, training and education on the next level, and mHealth and telemedicine at the top. We started with numerous workshops, presentations, and large conferences. Each event had a different focus on the type of participant, from government leadership to academics, to hospital and clinic workers, to students. We extended some conferences to regional thought leaders who could later act as role models and mentors. In these, we reached thousands of participants. And this is one of our core leadership groups here, and one of our very large regional and international conferences from the beginning. The next step was more in-depth training for those with a sustained interest. We worked to develop curricula through the University of Botswana and the local nursing and healthcare worker schools and colleges. We had hackathons to inspire computer science students to come up with local solutions. And these were done jointly with the Penn engineering students, and they actually did their hacking and programming all night long. We sponsored health informatics master's students and PhD degrees, of which Kagiso Ndlovu will be receiving his PhD soon. This is the mHealth Innovation Competition, and you can see how many sponsors we had and the enthusiasm that's still there, our team that won, and how many interested students there were. Once we had trained healthcare providers, it was easier to begin developing telehealth solutions in all visual specialties, of which we have and still reach thousands of patients. One of the most important lessons has been to share what we do. These are just a few examples. A program where we helped University of Botswana medical students and residents gain access to information when they were seeing patients in remote settings. A program where we had worked with Microsoft to provide broadband internet connectivity in remote areas. This is an overview of our mobile telemedicine solutions in Botswana, headed by Kagiso Ndlovu. And this is an overview of our school screening in visual mobile telemedicine. And from here, I'll let Kagiso take over for the second half of our presentation. Thank you so much for having me.
Thanks so much, Carrie Kovarik, Dr. Kovarik, for the wonderful presentation, handing over to me to speak about the key highlights in terms of the global health informatics collaborations, the successes and the challenges. The focus of my presentation will be around key successes and challenges around capacity building initiatives that we conducted here in Botswana. And also I'll talk about specific successes and challenges for e-health projects, that we hosted in country. So this slide here just highlights the University of Botswana's e-health research unit, which I coordinate. So you can see, by the look at, the pictures that we are a very diverse group. We collaborate, with, various, stakeholders. So these are some of the Penn students who intended the e-health research unit, and they're working on various projects. Supporting some of the work that you do here, research, and also capacity building work that we do within the e-health research unit. So starting with curriculum development, which is of course a capacity building initiative. So we collaborated with UPenn, and of course working with other key stakeholders here locally to develop a health informatics curriculum, which we are currently offering. So it's a semester-long curriculum on health informatics. So we offer that to health science students. And then, of course, we are looking into having a professional health informatics course offering rather, as time progresses. We have collaborated in the past with other universities also, like the University of Western Cape, where we were co-teaching an MSc in Health and Knowledge and Information Systems. And then, of course, we used, some lessons learned there, to help us, with the draft curriculum that we are having here at the university. To do with health informatics. We have an institution here also that was supported through global health informatics collaborations that we have that we currently or that rather we had at the time with UPenn. So the institution is called Botswana University, and they were assisted to develop a curriculum on health information management. One of the key highlights also from 2019 under capacity building was, the successful hosting of the Health Informatics in Africa conference, otherwise known as HELINA. So this was a success in the sense that there was government buy-in through the Ministry of Health. We had BITRI, we had Botswana Health Information Management Association, and others, from the private sector who came in and collaborated with the University of Botswana to successfully host this. And we had audience and speakers from all over the world, all geared towards building capacity around data health or e-health in Botswana. So this is a slide just showing one of the success stories here in Botswana to do with health informatics or capacity development around health informatics. So three of us, I also benefited in this program. We had, the privilege to be awarded a FAAD grant to study PhD in telehealth. And we are different stages. So Dr. Maucho has already graduated in 2021. I recently submitted my thesis in July 2022. Looking forward to graduation. And then Benson Ngube is still having his PhD research work ongoing. So this was a huge milestone that came out of the collaborations that we had with University of Pennsylvania around health informatics capacity development. And then of course another key highlight is the formation of the Health Informatics unit. to drive, all health informatics initiatives, under the Ministry of Health. So the gentleman on the far right there is the former Health Informatics Director at Ministry of Health. And then he handed over to the current one, Mr. Chabani, who is actually directing that particular unit, overseeing all health informatics work. So this is all a result of the successful collaborations that we had, with various stakeholders, including Penn, around health informatics capacity development. One of the key highlights, also another success story through collaboration, that we had, over the years, was the development and implementation of Botswana's first national e-health strategy. And this was a strategy that was informed by WHO and ITU, strategy toolkit. The strategy currently has 7 pillars, as you can see on the far right there. So these are some, the strategy framework with pillars. The cross-cutting pillar, leadership and governance, and then strategy and investment, services and applications, standards and interoperability, all of which are geared towards supporting healthcare provision in Botswana, through use of, health informatics or e-health technologies. And then, of course, not only does the strategy focus on the technology, it also looks into issues of governance or coordination, and also, human resource capacity development. So this is a success story, and the current strategy runs between from 2020 and it would end in 2024. So we are so excited about this initiative that came as a result of the the previous collaborations. So the document there. So shifting gears a bit and talking about e-health projects in terms of the success stories, and of course some key challenges worth highlighting. The first success mobile telemedicine project was called Konafalo, and this was a store and forward type of telemedicine initiative, which was led by Botswana UPenn partnership in collaboration with the Ministry of Health, and of course there were other like telecoms providers and a local IT company that was engaged by the ministry to develop that telemedicine solution. So this project cut across 4 medical specialties: oral medicine, cervical cancer, dermatology, and radiology. So what will happen is that a clinician will take a picture, of the lesion or the skin lesion, or maybe the radiography film, and then add some data, associated data, to that, and then they will share that using a mobile device via data bundles that are loaded in those mobile devices. The specialist would get a notification email, and then they'll review the case, and then send back a prescribed course of treatment, to the clinician. So there's some benefits that led to this project being, considered for national scale. As you can see, the slide here shows that then the permanent secretary for Ministry of Health and the CEO for Orange Botswana, there was exchanging an MOU, after the signing ceremony, where Orange Botswana donated some mobile devices and some data bundles to support the Konafalo project. One mHealth telemedicine solution also worth highlighting is the portable eye examination kit, otherwise known as Peak Vision, which was for supporting visual acuity screening. So this was piloted across several schools in Botswana, within one district, and a lot of kids benefited out of this. Some were medicated, some received spectacles. This was a project that was funded by the Queen Elizabeth, Fund, and then of course there were some collaborations here internally. University of Botswana participated in some of the validation trainings. There was also participation from the Ministry of Education and Ministry of Health. Both of them were beneficiaries because this was piloted in schools. So 49 schools were involved. Over 12,000 kids were screened, as you can see in the pictures. And going forward, government commitment was acquired to support national rollout of the program. As you can see, this picture highlights our current leadership being demonstrated the potential of Peak Vision mobile application towards visual acuity screening. And then there's a project that is still underway, for national rollout, and we are so excited the collaborations that we had with PIC, based in the UK, who were the the solution providers or service providers. Some of the key challenges worth highlighting, in terms of health informatics or e-health in Botswana. We've had, in the past, the lack of e-health and telemedicine policies. Even at the moment, we only have a strategy, like an e-health strategy, which is driving all e-health interventions or initiatives in the country. But there is need, for a policy, that would guide telemedicine, direction, and also that will speak to the strategy in terms of what should be key considerations when practicing telemedicine within the country. We've had frequent leadership changes, something which actually hampered progress. 1 minute you have buy-in from the leadership, and the next thing, new leadership is introduced. So that was so that has been a challenge over the years. Inadequate funding or budget for e-health project and skills development. More often would rely on external funding. These over the years, there's not been a dedicated budget towards health informatics initiatives in the country. Just recently, when the ministry started the health informatics unit, that's when they started allocating some small budget towards that department to support human capacity development, primarily. And so we're hoping that going forward with the implementation of the strategy, the e-health strategy, we'll see some budget allocations. Otherwise, the external funding has been very limited. Comes with some restrictions or some conditions, some of which would stifle innovation. Innovation in country, and also affect the sustainability in a way, because it comes with some terms and conditions. Poor internet connectivity across our healthcare facilities also has been a constraint. Most of the facilities, yes, they are connected to some sort of internet bandwidth, but that has been weak over the years. And the government is currently undergoing through some digitalization project to make sure that all such facilities are upgraded. Too many vertical programs affecting strategy implementation. So there's been a lot of programs under ministry, and also across various NGOs, sort of duplicating each other's efforts, and that actually affected implementation of the overall strategy, for health informatics or e-health. The joint public and private sector is another challenge worth highlighting in Botswana, which resulted in non-interoperable e-health solutions or even health information systems. So this has sort of, also led to duplication of efforts, overspending, and also, affecting decision making, at national level, because there is no sort of a collective data sharing that would inform, how ministry progresses going forward. Lack of e-health expertise, even though, the collaborations that we've had in the past have contributed to some capacity development, we still don't have much, personnel here, or expertise, or experts rather, that are competent, to deliver an e-health project, and also, guide things going forward. I mean, there are very few in the country. So one would also, bring in the question of readiness, whether with such limited expertise, at least qualified, e-health experts, are we really ready, as the public sector and also the private sector, are we ready to adopt, such innovations? In some instances, we have some socio-cultural barriers or issues, like resistance to change in some facilities. There were some instances in various projects where those type of challenges were encountered. Local ownership of solutions, because most of them, they were donor funded, and so they came with terms and conditions. And then some solutions also were imposed on some users or healthcare workers. So there was a feel that the solutions didn't belong to them, rather they were belonging to somebody else. So ownership was a bit of a challenge. And then lastly, the high staff turnover rates. So those who were trained or capacitated in e-health, ended up leaving the public sector to the private sector, to the private sector, or maybe leaving the private sector at all, completely. Because of maybe retirement or something like that. So these are some of the key issues or key highlights that I would want to point out in terms of challenges, considering where we've actually came from, as a country with regards to health informatics and the global collaborations that we've had with various stakeholders. So we've been a diverse team over the years. As you can see, the slide here just shows the different members of the team that collaborated under the Botswana UPenn Partnership Health Informatics Program. And then, of course, we had some BUP Health Informatics Program that are based in Philly. So Dr. Kovarik is there, Tony Lubeti is there, John Holmes, Jonathan, and Anne. So all of them, contributed to the success story that, I just alluded to here in Botswana. I've recently joined also the University of Botswana, transitioning from Botswana UPenn Partnership, and the support, still continues, from Penn, even when I'm still at UB. So you can see here also other members of the team. So indeed, we are a very diverse team. We've had health informatics program, the team members based in GAPS, as you can see, the ones at the top there. We've had some health informatics students, volunteers, fellows, and interns from Penn and CHOP, who also participated in our program, and also the success story that we have here in Botswana. So quite a diverse team that we are, and of course other collaborators, in various roles such as principal investigators, worth highlighting Dr. Masire, Doreen Masire, Watokwa, Andrew Steenhoff, Harvey Friedman, Rob Gross, Dr. Motsahwa, Michelle Johnson, Neo Tapel, and many others, that are here in the slide, that we appreciate their support and guidance, throughout the health informatics journey in Botswana. So we had some values that kept us together. Communication was one of them, transparency, flexibility, and fun. So we believed in deriving fun or deducing fun out of the work that we do, and then teamwork and growth. So those are some of the key values that kept us together as a program. As you can see in the slide here, how neatly joined we were as a team in one of the boardroom meetings. Thank you so much. That's the end of my presentation, and thanks for the time. And I look forward to any questions and comments.